a session, a special session, being done by Zichire, an organization which operates in Zimbabwe. Our session is going to be led by Chikanya, whom I have here in front, who is the director of the Zichire organization. The presentation is going to focus on strengthening male engagement in HIV prevention through community-led mentorship, with special focus or insights from the Brother to Brother program in Harare, Zimbabwe. So Walter is going to take us through how in Zimbabwe share the experience, the lessons they've learned on how to strengthen male engagement in HIV prevention, specifically through a program called the Brother to Brother program. In Zimbabwe, maybe like in other countries, there's an issue of low male engagement. So this program is aimed at addressing low male engagement in health programs, across all health programs. Thank you. So I'll give this opportunity to Mr. Walter Chikanya to take us through the presentation. Thank you.
Thank you, and good afternoon to everyone. I'm honored today to be here, and I'm also happy that I see leadership from my country. So allow me to also recognize the leadership from my country. Honorable Senator Tongogaro among the audience, thank you for coming. The chairperson for Thematic Committee on HIV and AIDS, thank you for gracing this occasion. I also want to recognize Honorable Bajila, chairperson Health and Child Care Portfolio in our parliament in Zimbabwe. I'm really honored to have leadership supporting this presentation. Let me also recognize National AIDS Council Management that is also present in the House, the directorship and the managers who are here, and the staff from National AIDS Council. Let me also recognize leaders from ZNNP Plus who are among us. I want to recognize you for coming and being in the House. Civil society organization that are here from Zimbabwe and other countries that are here, directors that I also see in the House. Let me really recognize you. It's a pleasure to have you here. Today, I want to talk to you about a program called Brother to Brother, which we have been using as an organization to address the gap that we identified. I think I might need help. Okay, looks like it's now moving. So, our idea of, okay, thank you, organizers. So our idea of working with young people 10 to 24 years came when we realized that we do have a lot of programs that are currently addressing the needs that have to do with adolescent girls and young women. And then we realized that there was that gap where we are saying, who is going to empower the young men to be able to then deal with the empowered young woman? We saw a lot of programs in Zimbabwe, typical one being the Dreams. And then, but you know, our statistics, if you look at the HIV testing rates for adolescent boys and young men, they've really been showing that they are a bit low in comparison to their counterparts, which are the girls. So for us, we really realize that it's very important for us to then address the issues that have to do with boys. If you look at the issues of drug and substance use currently in our country, we have a challenge where our young people are using drugs and substances, but if we look at the comparison, about 66% of those are actually male. So for us, it became very important, even looking at the stigma index, it's even showing that, you know, within our young people, there's need for us to also be addressing them so that they can also address issues to do with stigma. a number of references. There's an Ask for NDS1, the National Development Plan that we have as a country. Also identifies young men as a priority group that needs to be addressed when it comes to interventions. So for us, we really saw an opportunity to then say, if all the statistics are really showing that there is need for us to address young men, how about coming up with a program? And as detailed right there, PLED mentorship has proven to enhance HIV testing, PrEP uptake, and adherence. So, and this is WHO 2023, clearly showing that if we work using peer-led models such as brother to brother, we can really be able to encourage young men to go and get services. In this picture here, we really see role modeling. In our country, we have the premiership. I don't know in other countries when it comes to soccer, because this is a model that uses sports, integration of sports. So here we've got some of the players from senior teams in our country that have gone through the brother-to-brother program. For those who are from Zimbabwe, on the far left there, the player there is a left back for Caps United. And this young man has gone through the program, and now he's actually mentoring other young people and encouraging them to also receive services and making sure that they also get tested. Right at the back, we've got one of the strikers from Dynamos. So for us, we really saw the need for us to come up with a program like the brother to brother. So what is brother to brother? What is the approach? So this is a club related, so there's mentorship through clubs. So what you have is peers mentoring each other. We don't want a setup of a teacher or facilitator, but this is peers talking to each other and sharing experiences and then making sure that they refer each other for services. But within the community, we also then work with structures that are already in the community. Our leadership, such as the councillors, National AIDS Council, Ministry of Health and Child Care. So we've got a number of structures that are on the ground that then help us to then select the mentees who join the program. But what is also then important is that we also have a screening tool, because what we are trying to do is also have vulnerable young boys be part of the programs, those who are not really accessing services. So we have a screening tool that they use for them to be part of the program, which is the risk assessment tool, which really shows us the level of risk that these young people are at, and then as an entry point. But also at entry point, there is also testing. All of them, the young people who are part of the clubs are also supposed to get a test at entry point, and also then a test at exit point when they graduate. So this is just to give a conceptual framework of what the brother to brother looks like. So right at the top there, we're just showing how we recruit the adolescent boys and young men into the clubs. So we're looking at the walk-ins that come on their own, also art clubs. We're also looking at soccer clubs, academies, schools, community itself. So once these are referred, they then go through the screening process I was talking about. That tool now that will assess the vulnerability of the adolescent boys and young men. But on the far right, we're really looking at now what then happens once you are in the club. There's a double barrel where we are also looking at other services. For instance, Zimbabwe Republic Police, for those young people who come with issues that then require the authorities to deal with. Maybe they've gone through abuse, there are issues that they're going through. We also have the churches. Churches are very important, faith-based organizations, because we've realized that our pastors and prophets, they engage with our young people and communities a lot. And in Zimbabwe, I think people are predominantly Christian. So we have a lot of people who then attend churches. So for us, we also enjoy that relationship where we can also refer, and also the churches do refer to also the brother-to-brother program. The senior soccer clubs, an example I've just shown in that picture, where the senior soccer clubs, was what we're also doing is we also want these young people to also identify their talents, and they can also join other soccer clubs. Okay, this is just a picture to show the recruitment that has been going on. But what is important about this is just to show how important it is to work with mobilized communities. For us, the academies, the schools, the soccer clubs, young people are already mobilized. Otherwise, without such a setup, it's very difficult to then mobilize the young people. You can move. So this is just a quick cascade just to show some of the services that the young people are receiving when they join the clubs. So looking at HTS, so recruitment at 99.7. But what is then interesting is, like, for those young people who were then found to be positive, the 4%, there was 100% referral. Because for us, it's very important for then the young people to end up receiving the services. It's very important for them to have access to the necessary health services. So also for male circumcision, medical male circumcision, we also referred some of the young people who we refer young people who come through the program. So in this case, an example of 560 ABYM who were recruited ended up being referred for services, about 80% referral. Then our redeemed referrals, then who then received the services. So we're looking at about 93% of those that were then referred for those services receiving the services. If you can move. So with the brother to brother program, this is a program where we're looking at not only giving information to young people, but what we want to see is young people accessing services. We want to make sure that it being a mentorship program, but at the same time, it's a program that should then lead to young people reducing number of new infections within their groups. So we're looking at that building of momentum, where we start like the snowballing effect. We start with 25 young people in one club. It's 25 young people, but within that club, we then expect diffusion of innovation, where we're expecting that those first innovators, those 25, can then cascade, can then make sure that their friends, their brothers also get to know the information that they are learning, because this is a manual-driven program where they go through a curriculum from building comradeship, club culture, and making sure that they also address issues to do with gender-based violence. Remember what I talked about earlier on. And also the issues that I raised earlier on of drugs. So this is also a cascade showing some of the referrals that are done during the program. So about 200 people who use and inject drugs identified within those clubs. Out of those, about 65% managed to receive mental health services, and about 34.9% then we received further management. Because what we're also looking at, if you go back to that graph that I showed earlier on, we have got where it says Zichire. That's a drop-in center point where we are saying, after going through all this and young people get to understand information, are empowered with information, they're asking us to say, okay, what if I then decide I no longer want to use or abuse drugs? Then what is in it for me? What's going to happen to me? Remember the problem that got me here, that got me start using substances, because I was facing some mental health issues. But now that it's okay, I need something. So we're also looking at equipping them with also life skills, economic skills. Okay, if you can move. So just to bring that up, like to just back that up with some of the success stories that we've been seeing in Zimbabwe. So here we've got Munashe, a 20-year-old young man in Harare. The young man was engaging in risky sexual behavior. He had not gone through the process where, someone is teaching him, what do you have to do? If it's your first time to have sex, the processes that you go through. And I think any parent in the house can also attest to the fact that it's very difficult to sit down with your own child, your own daughter, your own son, to really take them through SRH issues, especially when it comes to sexual matters. I remember the first time I tried to talk to my boys about condom use. It was very difficult. I ended up having to get someone to come and start the conversation. But what was interesting about that is that, my boys had grown, but they actually didn't know how to use a condom. And I feel this program has also exposed that, has also really shown that gap, that sometimes we even need to cascade the conversations even beyond the program itself, even to homes, and make sure that it's not only programs that are talking to our children, but us as parents also need to give sexual reproductive health information to our children. So some of the success stories that we have, because we're not only looking at giving information, but we want to empower these young people beyond. So we have got a component of life skills that I was talking about. So we have got about 10 mentors currently and 25 mentees who started programs in an area called Epworth in Harare. Now, just yesterday, they were sending me videos of them now making sofas, beds, but it just started in the program and we're referring them for training, and another organization came through and managed to train them on carpentry. But now, at least they then say, we don't have idle time. Now we are busy all the time, and we're also making money, and we can be able to avoid drugs. Transformational leadership, just looking at what the program has also done, we have got some mentors who have become leaders in the communities. For example, counselors. We actually have an example here of a mentor who went through the program, but now he's actually a community leader and ambassador. He's also working for one of our newspapers in the country, also writing articles for the newspaper. Some of the key achievements, just to give a sum up of what the program has also done. I have to give it to Ministry of Health. Through the Ministry of Health, we were equipped with self-test kits that we managed to distribute to the mentors who are working with the mentees. And now, because of that, initially we're struggling to really get the boys to get tested. They're saying we don't want to go to static sites, a number of issues that they were raising. But what is interesting now that it's their mentors, it's their peers who are distributing the self-test kits. They're actually getting tested, and we've seen an increase in the number of boys who have been tested at entry and at exit also. If you can move. So some of the impact that we have seen. 80% of our adolescent boys and young men are now aware of their status. Really looking at the cohort that we are working at with, and we are happy that also we're looking at the 95 targets. But also, what is interesting also is that increase in the uptake of also VMMC as one of the method for prevention. We have also seen, through a tool that we use for mental health counseling, we have also seen a general reduction in reported depressive symptoms among the mentees, the young people. 67% of the participants accessing psychosocial support and counseling. So for us, this program has been really helpful in terms of allowing our young people to be able to access the different services that they need. And like I mentioned earlier on, it is for us critical to close that gap for young people and adolescent boys and young men accessing different services and making sure that we reduce new infections among that group. Let me take this opportunity to acknowledge National AIDS Council. being the main funder of this program through a social contracting program that we have in the country. Ministry of Health and Child Care being our parent body. Icasa, Ministry of Youth, they've been very useful in terms of mobilizing the young people and in terms of recruiting them into the different clubs. Civil society organizations that we work with, some already in the house, others back in the country. The staff that worked with me also for this abstract. So I want to thank you and thank everybody who came to this session. Thank you.
Okay, thank you, Walter, for the presentation. The presentation was very detailed and on time. I know that he could not say all the issues in the program because he could have gone on and on. So I can see in this room, there are policymakers who are here. There are different people with different expertise and background. There are also people who may want to share experience, who may want to learn. I can also see some possible faces of possible collaborators to this program. So I want to give this time to the people who have attended this session. If you have questions, clarifications, comments, you may want to make out of this presentation. Thank you, Walter. Okay, the mic is coming. It's next to you. So we'll take a round of 5 questions, then he respond. Then we'll take another round if there are any more questions, clarifications, and comments. Thank you. You can go ahead.
Okay, thank you very much for the presentation and the novelty of the idea. My concern is, do you have any arrangement to take care of ethical issues that may come up in this? I understand that, you see, the brother-to-brother program is a pair-led program. How much secured is it such that it will not be abused? And in a case where you want to prevent abuse or make it to be a shelter for abuse, it becomes a point where people are abused. Then, is there an age limit? Because you say adolescents and children. For those who are less than 18 years, who gives the consent to recruit them into the program?
Thank you for that question. I think for this session, for the people who ask comments, you can introduce yourself so that maybe if there are some follow-up interactions which need to be made, Walt will be able to do it. Thank you.
Okay, thank you very much. My name is Ochonye Batlomi. I work with Heartland Alliance in Nigeria. And interestingly, we also work with a lot of men, though not only young men, but more than 80% of the men are young as other population. But the interesting aspect of this is also that you have a lot of collaboration and support with the government. For me, it's really exciting. But the main question is around the gap between the referral, those who refer for services, and those who actually, access those services. It's a similar experience, but I'd like you to share experience with us. What happens to those who failed to actually complete the referral and access those services? Because sometimes that is very critical to the success of the program. Thank you very much.
Okay. Okay, you can go ahead. Our Honorable Member of Parliament, Senator Togo.
Thank you very much, our moderator. I want to thank Mr. Walter Chikanya for this very wonderful presentation. First of all, I want to commend Zimbabwe for taking a different turn, because in most cases, everything used to be women, and men were being left out. in almost everything. If I give you an example of the key populations on sex workers, when sex work is being said, they refer to women, but it takes two to have sex. Now, if we include our men, we will achieve what we want to achieve. And I want to thank the National AIDS Council for this very wonderful program of involving men. And this brother to brother will go a long way to end AIDS, because men will be knowing what is supposed to be done. And I think even rape cases will decrease. So I just want to say that as a country, we must keep on involving our men, because it will go a long way in all the programs we are doing as a country. That was my comment. Thank you very much.
Okay, Walter, I'll take the last two because we have some more sessions which need to be done in this room. So I'll quickly take two only, then I'll ask Walter to quickly run down the responses. And after this session, if there are more people who want to learn, they can contact you. Thank you. I'll take the last two.
Okay, thank you. I'm Nathaniel, and I work with Proactive Global. I want to go a step further with what the question my brother from Nigeria asked. He wanted to know, those you refer, the referral, are you able to gauge those who actually get access? I want to go a step further. After they get the access, are there mechanisms in place to check if they are actually adhering to their medications, and how many of them are able to reach the U equals to U stage? Thank you.
Thank you very much for the presentation. You stated that you are reaching out to boys between the ages of 10 to 24. I would like to find out how their parents are being engaged, especially those who are around 10 to 15. How do you engage their parents? How do you seek for parental consent, especially when it comes to HIV testing and all that? Thank you.
Thank you. I'll give the time to Walter to answer.
Thank you very much. So, let me get up. So, I'm happy that someone picked the age. There was a question on the age. Someone picked it. It's 10 to 24 years. Thank you. And then the issues of abuse. I think in the conceptual framework, you saw how we are working with authorities, law enforcement agencies. This is why I talked about Zimbabwe Republic Police. They've got a victim-friendly unit. So we work closely because some of the issues we can't handle them. So what we then do is use that structure so that we refer them. So we have them coming now and again to even address the young men, and so that we don't have those cases of abuse. So far we have not faced any serious cases of abuse that really needed the Zimbabwe Republic Police. Then on the collaboration, yes, indeed, there's been strong collaboration with the government and National AIDS Council here present, its management and directors here. I'm happy that they have supported this program very strongly, and now we've got a social contracting funding mechanism. So this is purely funded locally. It doesn't have any external donors. It's local funding coming from National AIDS Council. So we are really grateful for that support. And we continuously get support from Ministry of Health and Childcare. I'm happy some of the bosses from Ministry of Health and Childcare came after I had done the citations. I see Dr. Mguring. I also see my doctor from Harare, our PMD, Provincial Medical Director here. And this program is in Harare, so I'm really excited that he's here. Also, the other question on referrals. Yes, it is always an issue, a thorn. It's a big issue. You refer, and you can't really force somebody to go and access the service. And behavior change is a process. Someone might decide after a month to go and access the service. Someone will decide the next minute you tell them. So we also need to give them that opportunity. But what is important, remember this is a peer-led. So these mentors are from the community. So they meet now and again and they just remind each other, oh, by the way, did you receive that service? Oh, what happened? You were also asking what happens when they come back. There is that follow-up process where they check on each other. So there's that. So you don't really go out of, look at those players I showed you. They were in the program, I think, some 3 years back, but they're still working with others. So there's that building of momentum. Then, Senator, thank you so much. That's so encouraging from the leadership. I'm happy. We'll take that home, and National AIDS Council is here also hearing about that. Then the parental consent. For us, like the younger ones, we make sure that the parents sign. There's a consent form that they sign, and we also take the parents through the process, the brother-to-brother program, and what the boys are going through. We actually divide these groups into two, 10 to 15, then 16 to 24. So we have really realized that the parents are really supportive of the program because, remember, we are choosing vulnerable boys through that screening process. They are already vulnerable. So the parents are actually happy to see their adolescent boys and young men going through that program because of they were already problems when we got them in. Otherwise, thank you. I hope I managed to answer all the questions. Thank you.
Thank you, Walter. You can take a seat. We have two more presenters. I think in terms of time management, if I was employed somewhere, I could have lost my job right away. So I'll invite the other presenter. So for the two presenters who are coming, they will present, then we'll take questions later to manage time. Thank you. What I'm going to do, because I'm a bit poor in terms of management, I have a communication breakdown. I'm a communicator at our organization, so I talk a lot. So I'll leave the time to the presenter to manage his time. So he will introduce himself, he will introduce the topic, so that there's less talking from me. Thank you, sir.
Yeah, thank you very much. Welcome again. My name is Dennis Annang, and I work with the Ghana AIDS Commission. And you're all welcome to Ghana once again, though you have just 1 day to leave, at least for the those who are not Ghanaians. Okay. So this presentation examines the reach of peer-led HIV interventions among female sex workers. And we use the data from the 2020 Integrated Bio-Behavioral Surveillance Survey. And I would quickly go through the slide, just like the chair said. Sorry. Okay. Okay, so I'll attempt to give a country context in terms of the HIV epidemic. So currently, our estimated population of people living with HIV is about 334,721, with 69% being females and about 5% children. Our current HIV prevalence for the adult population is 1.49. New infections are also estimated at 15,290, which accounts for 2/3 of new cases in the country. Although Ghana has made progress towards the 95 target, there's still gaps to be completed. And for female sex workers, the current IBBSS states that the prevalence is 1.46, which is more than 3 times the national prevalence. Okay. So Ghana's epidemic, like I said, is a generalized epidemic with concentrated sub-epidemics amongst key populations, including female sex workers, men who have sex with men, and transgender group. The first case of the first case was reported in 1986, and the epidemic has since evolved with increasing heterogeneity across the regions and population. Next slide. Yes, the Ghana East Commission coordinates the HIV response by providing strategic oversight for HIV prevention, care, human rights intervention. With this framework, targeted programming for key population is prioritized to address structural, behavioral, and biomedical drivers of HIV prevention. And female sex workers face overlapping vulnerabilities, including stigma, criminalization, mobility, and exposure to sexual gender violence, which limit access to conventional health services. Peer-led interventions are therefore a core component of Ghana's HIV key population program, as stated in the key population SOP. So we would now try to understand what peer educators are and what they do. So peer educators are trained members of the KP community that's able to effectively offer direct outreach through one-on-one on small group communication sessions. These outreach sessions are designed to share information regarding transmission of HIV, means of infection prevention, distributing and educating people on the use of condoms and water-based lubricants, providing access to intervention relating to specific risks and vulnerabilities, including risks of sexual and gender-based violence, promoting adherence to ARVs and other biomedical interventions such as PrEP, and providing referrals as appropriate. So in trying to do this analysis, we tend to assess the proportion of FSWs who have been reached by peer-led intervention nationally, and also analyze the variation in the peer educator contact across the different age groups and geographical regions, and identify coverage and propose recommendations to improve equitable access to HIV services. So in doing this, we try to justify why we are doing this exercise. And the data from the 2021-2015 IBBSS states that peer educators are the key source of condom for a lot of the FSWs. So for 2011, you realize that 30% of the respondents mentioned that they receive condoms from peer educators. That is for FSW who are roamers, and for the CTES, about 47% said they receive condoms from peer educators. When we looked at the 2015 data, it is clear that condoms for female sex workers were mainly from peer educators, which gave us a figure of about 51%. So this forms the justification to understand why we needed to carry out this analysis. So we used the data, just like I said, the 2020 IBBSS data, which had about 6,773 FSWs as respondents. And for peer-led intervention reach was defined as contact with a peer educator in the 12 months preceding the survey. So the results clearly shows that, so we also tried to include the 2011-2015 data. So from 2011, the figure we arrived at was 56%. That is, in all, about 56% of FSWs have had contact with a peer educator. And this increased to about 70% in 2015. And the 2020-2019 data, that declined to 52.4%. In terms of accessing the regional divide, you would realize that regions such as Bono East, so Bono East is one of the 16 regions of Ghana. So regions such as Bono East, Ashanti, and Greater Accra had the highest respondent mentioned that they have contact with a health peer educator. And in terms of age, you realize that it is the 50 plus who are confirming that they've ever been in contact with any peer educator in the community in the last 12 months. The younger female sex workers are not doing too well. Yes, they are not doing too well. The 16 to 24, you had 43.3%. So what does the finding tell us? It tells us that peer-led interventions are more effective among older age groups, just like I mentioned, with significantly lower engagement among younger FSWs. The regional disparities also reflect an uneven program coverage, with urban centers such as Ashanti, Accra, so Greater Accra achieving the higher reached compared to the newer regions such as Western North. So Ghana had opportunity of creating new regions in, I think, 2019. So Western North is one of the new regions. And currently, the KP programming across the regions is in about, just about 13 regions. So definitely Western North, one of the regions to look at. Barriers to participation among female sex workers may include, we tried to also understand what could also be the reason why the FSWs or the younger FSWs were not engaging the peer educators. And these suggestions are based on understanding what the data was telling us. So include stigma, lack of trust, or reliance on digital socialization platforms that limit physical outreach opportunities. Also more because their work is a bit criminalized in a certain way, not officially, but they then tend to prefer to be with people they trust. So what are we recommending? We are recommending that for the KP programs in Ghana should be intentional about recruiting and training younger peer educators. This is to help improve engagement among adolescents and young adults, young female FSWs. And the program should scale up in underserved regions such as Eastern, Western North to improve national equity in the service reach. And digital outreach strategies include the use of social media mobile platforms should be integrated into peer-led intervention. I must say that some programs have started using that. So they have social media liaisons where they then try to interact with female sex workers. So conclusion, so peer-led intervention remains central to Ghana's HIV prevention efforts among female sex workers. Overall contact coverage of 52.3% represents progress, but indicates that nearly half of the target population remains unreached. So currently the estimated FSW population is around 60,000. Strengthening age-sensitive and regional balance outreach strategies will be essential for reducing HIV vulnerability and achieving equitable service. Thank you.
Okay, thank you, Dennis, for that presentation. The last two presentations have been done by men. I'll take this opportunity to invite a lady to come and present before us. I know all of you have your phones, and definitely in your phones there's a notebook. In that notebook, kindly take down the questions you have for Gerald, then the questions you are going to have for our wonderful lady. What I'm going to do, like what I've said, I talk a lot. So I'll leave this time to the lady to introduce yourself and also introduce the topic you are about to present and start the presentation. Thank you. I'll give this to you.
Thank you. Good afternoon, colleagues. I am Lydia Oluchukwu, Efobi, from the Person-Centered HIV Research Team, University of Nigeria, Nsukka. And my topic is Decoding Prevention Behavior, Education's Impact on PrEP and HIV Testing Uptake Among Female Sex Workers in Southern Nigeria's IDP camp. Okay, so before I begin, I would like to tell us a story of a 27-year-old woman in Calabar's IDP camp. 3 years ago, displacement forced her into sex work to survive. And then 6 months ago, she heard about PrEP. But she asked questions. Where would she get PrEP? And then the answers came in English that she barely understood, with to locations that felt very strange, and in terms that also felt like a foreign language. Now, I need us to understand that this woman, she never finished primary school. Her education ended at age 11 when her village was attacked, right? And so 15 years down the line, we see someone that has lost education, and lost education means lost protection. It's like knowing how to save your life, but not knowing where that salvation is. So, while we understand that education critically informs preventive behavior, its specific impact on PrEP and HIV testing use for female sex workers within IDP camp remains unexplored. And so it is this gap that this study is set to fill. So our objective was to examine the impact of knowledge of PrEP and HIV testing and the impact on varying educational levels on female sex workers' access in Calabar. So to do this, we conducted a cross-sectional survey using random sampling and a 3-part validated 17-item questionnaire. We collected data from 108 female sex workers, and that spanned from December 2024 to January 2025. So the descriptive analysis was done using IBBSS version 27, and then we used regression analysis to identify independent predictors of access. So what did we find? Found that 23.1% of this population were aged 25 to 34 years. 36.1% stated that they had been in sex work for more than 6 years. And then when we compared education levels, we found out that 39% of these women had no formal education, while only 6% had higher education. And when I mean higher education, I'm talking up to university degree level. Now, here's the painful story. 87% of these women stated that they had access to PrEP and HIV testing, meaning that the services, they exist, the clinics, they are there. But 9.3% of these women reported no access at all. Now, no access not because the services do not exist, but because geographic availability doesn't actually equal access when knowledge is a barrier. And so we also had that respondents with secondary and tertiary levels of education assess HIV testing regularly, while those with no formal education had no access. Now, let me repeat that. Zero utilization amongst women with no formal education, which defeats the global HIV response of not leaving anyone behind. And our regression analysis confirmed that education and knowledge of this HIV prevention service location independently influenced regular access to PrEP and HIV testing. So now, independently influence is the key phrase there, because even when we control for other variables, education still matters. Knowledge of this service location matters. And the flip side is that lack of education of this, or rather knowledge of this service point, emerged as a significant barrier to utilization. So, what does this mean? First, the services exist, but the knowledge pipeline is broken. Now, we're not communicating effectively with the population that we are trying to serve. Our information dissemination strategies are failing the women that actually need them the most. And then the second thing is that more educated women, they access these services regularly. right? Now, it's not because they are better at health seeking, but it's because our systems are usually designed for the educated populations. When we go to outreaches, we share pamphlets. Pamphlets assume literacy. When you go to clinical signage in the hospital, they also assume English fluency. And we as health workers, we assume our patients can ask informed questions. Now, what do we recommend? We need more enlightenment and improved service visibility. Now, I'm not talking about pamphlets. I'm talking about video and audio visuals being used. Now, service visibility means that we stop hiding behind the whole professional jargons and bureaucratic processes. It's more about having clear these signages in multiple languages. It's more about bringing these mobile clinics to the to the camps, and having peer navigators who walk these women to their appointments to provide support to them. Every woman who cannot access PrEP or who can't access PrEP because she does not know where to find these locations is a preventable infection. And every missed HIV appointment is a delayed diagnosis. Every structural barrier that we fail to address is actually a violation to the right of health. And we as Africa, we can do better. And this research shows us exactly how. Okay, so I want to close this presentation with an invitation. This year, the Society of AIDS in Africa celebrates its 35th anniversary under the theme Africa in Action. And I would like to translate that Africa in Action to Unity in Action. Now, I'm not talking about unity in meetings and unity in reports, but more of unity in implementation. I'm standing here not to present just as a researcher presenting findings, but as someone who is asking for collaboration. And that's why I'm inviting fellow researchers. Let us also replicate this research in other contexts so that we can test the validity and credibility and also the reliability of these findings. I welcome your questions, your insights, your critics, and most importantly, your partnerships. Thank you very much.
Okay, thank you very much, Lydia. You can sit here for, I think I'll request 2 minutes of your time because we have another session coming. So I'll take 2 questions, 2 burning questions, if there are any questions, quickly so that the other sessions can start. Then there's another one. The questions are coming from far right and far left. Thank you. So, can we do it quickly before I get fired?
Yes, thank you so much. Aputungwepe from South Africa. My question is actually on the latter speaker. I just want to find out if there was any comparison that was made with male sex workers. And I'll mention why. We normally see a lot of trends that focus on female sex workers. But the male sex workers are often, not considered. Those are male sex workers that are having, sexual engagements with females. And we've got those that are having sexual engagements with males. So I just want to find out if there was anything that was done in that regard. Secondly, still on the same topic, was there an assessment of their practices? In other words, what kind of practice are they following? Are they using these particular methods but not knowing what these methods are? Or is it a matter of them not knowing exactly what HIV prevention means, in other words? And then maybe the last one, still on the same speaker. Are there, based on your study, are there any immediate interventions that should be prioritized, perhaps just to fill in that particular knowledge gap that you have identified? Thank you so much.
Thank you. Those were three tough questions. Take note. The last one.
Yeah, good afternoon. My name is Dr. Ivezio Pukoro. I work with the Institute of Human Biology Nigeria. And just to say thanks to Oluchi, right, for that great presentation. And to let you know we are open to collaborations and partnerships, so feel free to interact. But my question is just twofold. One, it wasn't quite clear how you measured knowledge. I couldn't tell how you measured knowledge of the FSW. I wanted to get some clarity on how you measured knowledge and how you classified it. Because I know education generally is a measurement of socioeconomic status, right? And it's common knowledge that the lower education you have, the less, likely you access services available, maybe because of lack of, information. But I wanted to know what was unique about your finding. Was it knowledge, lack of knowledge of PrEP, or what really was your main finding that prevented this FSW from accessing PrEP? I just want that distinction clear in my mind so that I can get the message clear in my head. Thank you.
Okay, thank you. Those were the 4 questions for Lydia. And Lydia, I want you to quickly answer to those questions. We are on borrowed time.
Okay, so let me start with this so I don't forget. Okay. So, like I said during my presentation, during the method section, we administered a questionnaire that had 17 questions in 3 parts, right? So we assessed education, like knowledge levels. That was the first part of the questionnaire, mental health, and then access. Now, the specific, would I say the gap, would be not knowing where to get this test done, where to assess this PrEP that we say, oh, PrEP prevents you from having HIV. So those 2 things were like the, would I say something I found peculiar as the finding. Yes. Then your question, yes. So it said comparison groups, right? Okay. So no, we didn't compare any group. This was more like, would I call it a pilot study? Let me put it like that. Yes. So there was no comparison to any other group. So I didn't get the other question. Okay, that's a comparison between female sex orgasm. No, we didn't do that. And that's why, like I said at the ending, I'm inviting more collaborators so that we can adopt this study into other contexts. Thank you.
Okay, thank you, Lydia. I think Lydia and the guy, you need to see each other and talk, because there were some questions I think which were not adequately answered. It could also have been good for other listeners to get the response, but because we are on borrowed time, so I would like you to clap hands for our presenters for a wonderful presentation. Then lastly, a very short story. I would also want you to clap hands for me, because these 3 sessions had no moderator, because I'm seeing my supervisors, they are here. So they would ask me, why did you moderate? Maybe you got something from Icasa. So these 3 presentations, they had no moderator. I had just to come in to save the plane from crashing. Thank you. So clap hands for me.